our maximum of 500 attendees. So we'll have to send apologies to people who are trying to join now. This is really such a timely topic, racism, health, and healthcare. Where do we go from here? Next slide, please. And Sarah, I'm not sure if you're able to do that in the, hopefully people can see it from this mode. I'm Consuelo Wilkins. I'm the Vice President for Health Equity at Vanderbilt. And really this has been pulled together so quickly from our team, which includes, of course, not just me, but others in our Office of Health Equity who have worked really quickly in response to the current state of affairs locally as well as around the country to help us bring together some resources around anti-racism and help to put together a plan for us to provide these resources locally, but also really began the discussions about racism and health. Next slide. So this is actually a slide that I prepared for a talk in honor of Dr. Martin Luther King Jr. I gave it back in January of this year, and I talked about you know, one of his books, one that probably hasn't gotten as much attention as others, and that's you know, where do we go from here, chaos or community? And I think that really reflects where we are right now. You know, where do we go from here with all of the unrest and the racism that we're seeing, the police brutality in the setting of COVID-19. This is an important time for us to make a decision of where will we go next. Will we be able to come together as a community for our united good? Next slide. So why should we talk about racism and health? And maybe that's not a question we should be asking, but it's one that I think I've heard too many times over the last number of years. Why should we talk about racism and health? And I really, as a physician, I would say this is something that I find challenging because many of my colleagues sort of think about us as healers, as being a part of the healing profession, not being biased. And so the idea that we could be doing things that are racist or that we're treating people differently is a hard pill to swallow. But next slide. It's obvious that, you know, not so long ago, we were providing care in a very segregated health system. That was well into the 60s. And even when there were laws against segregation, when there was desegregation, all of those systems didn't just dissipate, they didn't disappear. They still do exist. And there are remnants of that we can still see in our health care environment now. Next slide. These go, you know, back centuries, and some of the things that we actually still hold on to in medicine and healthcare are based on biased beliefs and racial differences that were perpetuated to justify slavery. And it's unfortunate that we still hear trainees and physicians who believe that there are differences in pain receptors based on your skin color. So these things have not gone away. Next slide. We still are also holding on to race-based approaches like diagnostic tools, such as how we estimate kidney function using an equation that actually corrects based on your race. And that equation actually presumes that if you're Black, you have a higher muscle mass. And that's part of the reason it's justified as being used. Whereas we have plenty of ways to measure muscle mass. You don't actually have to look at race as a proxy. And next slide, I think this one is animated, so you can go to the next one. But a lot of this also is built on the premise that race has some biological or genetic basis, and it doesn't. And this has been, you know, frustrating for me in having some of these conversations about, that race is a social construct, and a lot of what we see related to health disparities is not just due to people of color having some, population differences at baseline, but due to differences in socioeconomic status, opportunities, disinvestments, discrimination, racism, all of those things that actually have an impact from the environmental standpoint on your health. And so I think if we're going to move forward towards actually eliminating health disparities into a place where everyone has the best possible chance of being healthy, we have to begin to talk about racism in the healthcare setting and think about how we can actually address this. So next slide. So I'm pleased to talk about, bring together again panelists here. Hopefully they're on this next slide. Pictures of them are on the next slide, I believe. Yes, here we go. We have really, I couldn't be more thrilled that we have this group of panelists here today. If we had been planning this for many months, it would have been a challenge to get this group together. So I'm just really so pleased that we have Derek Griffith, Jonathan Metzl, Christy Sinkville, and Willa Furuyama, who are going to share their insights with us today. What's gonna happen, each of them will give some opening remarks, and then we will have time for questions. Please put your questions in the chat box. We will try to get to as many as we can, and we'll go from there. So first up, we have Dr. Derek Griffith, who is a professor of medicine, health, and society. He's the founder and director of the Center for Research on Men's Health at Vanderbilt University. He's trained in psychology and public health and has collaborated with colleagues all over the world, and I'm honored to be among those he's collaborated with, or has been allowed to collaborate with him, I should say, to address such important issues like institutional racism. Dr. Griffith has been a contributor to many, co-author many publications, and recently is a contributor and an editor of 2 books, Men's Health Equity, a handbook, as well as Racism, Science and Tools for the Public Health Professional. Derek, thank you so much for your time today.
Well, thank you, Dr. Wilkins, for the invitation. Thank you for pulling us together. Really appreciate this opportunity to join in this conversation with you. I figured I would start by setting the stage and try to clarify, at least try to provide some context and foundation for exactly what we're talking about. There's often a lot of contention when we use the word racism about what we mean, and so I'm going to at least try to offer some context as well as definition for that as a foundation for our conversation today. The other thing I want to say by way of just introduction is the importance of what we see outside the healthcare system very much affects what you actually see in the doctor's office, as well as what you see in health and healthcare, whether that's public health or whether that's medicine, or whether it's broadly population health and the intersection between the two. And so it's important to understand how these factors play out in both contexts, as well as how the factors intersect between the two. So,
Dr. Griffith, you've been muted.
do I have control of the slides or do you?
I do, so just tell me next. And you're muted again.
Next. Okay, so we're seeing this pattern that we've seen many times before. And so there's this quote that is attributed to Mark Twain, or I'm going to take a version of it, that history doesn't repeat itself, but it often rhymes. And we see these patterns sort of over and over that look very similar. They may not look exactly the same, but they definitely look very similar. Next slide. We're in this moment where certainly one of the biggest precipitating factors to add to our attention from the COVID pandemic to now reemergence of these conversations around race, racism, police involved killings of Black men in particular, of African Americans and people in general, that we're sort of back at this conversation that we've been having over the years and certainly in the last few years, and that this is sort of the precipitating event or one of them that has happened recently that's sort of driving this recent conversation. Next slide. A few years ago, we were seeing this rash of these conversations and issues because of this exact same pattern, this exact same phenomena, whether it was Trayvon Martin and all the other, examples that I could have given you in the last 4 to 5 years, certainly going back as far as, other instances that I won't sort of get into details, but this is not a unique sort of phenomena, a unique pattern or a new issue that we're dealing with. It looks very similar to what we've dealt with before. And so part of the question that we need to understand is, why do these things keep persisting and happening in this way? Next slide. Well, it's very easy to look at these, again, as separate. The health, policing and what happens outside in the world as very separate from what happens in a doctor's office, in the relationship between a physician or a provider and a patient. We know that there's a lot of interrelationship, and we know that inequality in the quality of care and opportunities to be healthy exists both outside of the system as well as within it. And for more than 100 years, we've documented these things, whether it was from Du Bois's The Philadelphia Negro to other reports, including the Heckler Report in 1985. Certainly we had the Unequal Treatment Report in early 2000s, 2001, 2002, that talked about the inequalities in quality of care that African Americans and other groups received once they were actually in the healthcare system. And even when you took into account access to care, insurance status, and so forth, that you still saw disparities and big differences in the quality of care and the type of care that you received. So there is this important need to connect the dots between, it's not just enough to sort of look outside of those roles and look outside and get involved in things that are happening outside of your job role, but what's actually happening in the context of the specific roles that we're playing, and that we need to get to the point of dealing with, within particular people's roles, what is the thing that we need them to do differently in their job so that people can have the best opportunity to be healthy. Next slide. The question of why is going to be one that certainly has dominated our conversations throughout these times that we've sort of dealt with these kind of issues. This is a quote from a colleague, Amani Allen, but this issue of why is a really important one that we haven't sort of struggled and grappled with and forced people to articulate as much as we should, because it really does explain, how you define the why, how you define why these patterns exist, are very much going to dictate or certainly drive what choices you see as potential options for how you're going to address the problems that you see. And so we need to start having these conversations and really articulate, what do we understand as the reason behind these differences in opportunities to be healthy, whether it's involving with the police, whether it's when you go to the doctor, or whether it's just living otherwise in society. Next slide. So I just want to also be clear that when we're talking about racism, yes, we can get distracted with and talk about the specifics of particular events and incidents, like what just happened with George Floyd. We can sort of still, again, very much look at the incidents and patterns that we've seen of Black men getting involved in the police. Next slide. But we also, for this conversation to finally move to a point where we actually need to get to, it's important. The reason I use this image of an iceberg, which is certainly not a new analogy, is that certainly we see those things that happen, and we saw the recent events with George Floyd and all of those things, but there's so much deeper and so much more that is happening beneath the surface and that's going on that we really need to uncover, pay attention to, and deal with. And so structural racism is the concept that we need to look at these patterns that continue to persist by race, place, and across time. And that why do these things particular pattern by race? And what is this thing, the race that we're talking about? Next slide. And so again, just to reiterate that when we're talking today, we're not talking about, we'd rather not sort of get into the details of specific incidents, events. We really want to stick to this, what's going on in this larger pattern and system that we're seeing. Next slide. The last thing I'll say is just to offer a definition, certainly not my definition. This is from David Williams at Harvard University. It says racism is an organized social system in which the dominant racial group uses, or based on an ideology of inferiority, categorizes ranks people into societal groups that we call races, and uses its power to devalue, disempower, and differentially allocates valued social resources and opportunities to groups defined as inferior. So very quickly, the points I want to highlight in here is that we're talking about a system. We're not talking about, we're talking about why these things tend to pattern across healthcare, across, criminal justice, across education, and why are these patterns that we're seeing pretty persistent and consistent across even those different systems. That it's not just about difference. It's not just about who has blue eyes and brown eyes and that we see those, or people aren't always so gifted to be left-handed and so forth as I am, but you have these things that we see as actually having some real significance for people, that the differences that we see have deeper meaning, and that the folks who are designated in certain racial groups are actually seen as inferior to those who are actually designated in other groups. And that inferiority in that belief system has implications for who's safe, who's not, and how people are treated, and what resources and opportunities they have to actually be healthy, to be, to live out the American dream, and however we define that, to actually get the same return on education, to return on the efforts to go to seek healthcare, and those kind of factors that we know have very much important implications for people's health and healthcare. So thank you.
Thank you, Derek. That was great. Really appreciate you setting the tone and also giving those key definitions. Next, we're going to turn to Jonathan Metzl. Dr. Metzl is the professor of sociology and psychiatry, and he's the director of the Center for Medicine, Health, and Society at Vanderbilt University. Jonathan, I remember pretty vividly my first time meeting Jonathan, because he was one of the first individuals to send me a note when I arrived in Nashville, and I was grateful for to have his thoughts and insights on how to get my work here started. Jonathan, like our other panelists, I could go on and on about their accomplishments. Really, one of the things that I think is really great about having Jonathan here today is his insights over the last couple of years that he's reflected in many ways in his most recent book, Dying of Whiteness. So thank you so much, Jonathan, for being here.
Well, thank you. It's really an honor for me to be here and to be speaking on such a great panel. I'm not going to speak for very long, and I'm just going to go old school and not use slides. So hopefully I'm not just like a little Max Headroom talking head here, but I just wanted to engage people. And it's actually great to see a gallery view of people and just ask a couple of questions. So as Dr. Wilkins just mentioned, I'm the director of the Department of Medicine, Health, and Society over in Arts and Science. I work with Derek and other people. And our center basically looks at the kind of social and political aspects of health and illness. And so first, I just wanted to begin with an open invitation for people who are aligned with the medical center to please come join us over in Arts and Science, because we're doing a lot of different kinds of anti-racist work. The work that I've done to this point, as you just heard, I've basically been studying race and health for a number of years. I had a large project that looked at the race-based misdiagnosis, overdiagnosis of mental illness, and particularly schizophrenia in African-American men. And that was a book called The Protest Psychosis. And then I've also just had a book come out called Dying of Whiteness, which is a book about the ways in which racial resentment brings us to, in a way, the crisis that our country is in right now, that in a way, if we built healthcare systems that worked for everyone, we would be much better off in facing something complicated like a pandemic. But unfortunately, that's not the case. We have these health disparities that are always present, and people live in those worlds every day, but they're also made clear in urgent moments like the pandemic, where the racially disparate health systems are reflected in different mortality rates. And really, as I argue in that book, the question is really, why don't we build better healthcare systems? Because it would help everybody. And there's a framework in the United States of what's called a zero-sum formulation of race, that basically we can't give something to them because that might take something away from us. And that's really the ideology that we have to get away from. But in my brief comments today, I actually wanted to talk about another project that's linked to those other two projects, which is called Structural Competency. It's a project that we're working on over at MHS and more broadly. In the comments here, I've put in a link to a JAMA article that we had come out this morning, which lays out a little bit of the argument. But basically, I want to challenge people listening with a question, Dr. Wilkins, that was based in your initial slide, which is, now is a moment for anti-racism. And what does that mean exactly? How do we become anti-racist, right? And if you think about the ways that medicine has addressed that problem for years, because it's not been, as you suggest, a secret, right? There are histories going all the way back of the ways in which, as much as medicine wants to rise above the biases of society, that in many ways, medicine also reflects those biases. Things like an illness called drapetomania back in slave times that basically made it a mental illness if a slave ran away, all the way through disparate rates of everything, you name it, pain medication, cardiovascular workups, things like that. And so in a way, what has medicine's response been to those issues? And I think it's important to note, and this is kind of my training when I went through medical school and residency, that we were taught when I went through training, the answer to that was something that I respect in many ways called cultural competency. I think, you know, when I did my research for the protest psychosis, I found something pretty shocking, which is that when I looked back in medical journals from the 50s, there was never any mention of race whatsoever. They would never say this patient was this background or that background. And that's because they didn't take statistics or data or anything like that about race or ethnicity. And so in a way, I think what happened at some time, which probably felt radical back in the day, was to say doctors need to pay attention to the racial and ethnic background of patients. And so in a way, what that led to was I think an educational system called cultural competency that we have today, that basically asks doctors to say, what is a patient's racial and ethnic background, and maybe ask them important questions about what does that mean? How does that mean that you engage? And in some ways, that's very important, right? Because I think when people come to a healthcare system, they want somebody who's going to empathically acknowledge who they are and maybe even have a conversation about their background. But in the research that I've done and other people have done, we found ultimately that having a culturally competent doctor, as important as it was for particular in clinic conversations, it didn't really impact a lot of the race-related health outcomes that led to health disparities. And that wasn't because any particular doctor was or wasn't racist. I think doctors should continually fight to not be racist and not be anti-Black, which is what we're seeing in society right now. But I would also say that what we found in our research was that so many of the issues that were coded as being race-related, problems really were the result of far upstream conditions. Everything from the patients lived in an area where there was no access to healthy food. They couldn't get access to the healthcare system. There was no transit system that brought them to the hospital. They lived in an area where safety or police violence were rampant. Safety was poor, police violence were rampant. And so in a way, what we started to see was that the drivers, the root causes of many of these health-related disparities were the result of structural factors. That's probably not a big surprise many people who are listening here, and if you hear in my voice, I'm taking in part my inspiration from Stokely Carmichael's famous definition of institutional racism from 1967. But basically, Carmichael at the time said we spend too much time trying to sensitize people to be sensitive, when really what's causing race and injustice are these far upstream factors. And why is that important now? That's important now, I think, and as you'll see from the article that we did for JAMA, because I think what we're seeing with these COVID disparities are things that for all the world look like they are racial, just a certain population have an enzyme or a metabolism or something like that. But really these race-based disparities are a moment to really start thinking about what are the structural drivers, what are the root causes of injustice that are leading to poor outcomes, not just from COVID, but from other avenues. Now, the other part of this story, of course, is that doctors are afraid of that conversation, not because they're afraid, but because survey after survey shows that while many doctors agree that unmet social needs lead to worse health conditions for particularly for minoritized populations, but for all Americans, the same number of doctors also feel like they don't know what to do about it because they have 8 minutes with a patient and what can they possibly do? And so what we've done is devised a model that builds on other models like this called structural competency. And in the initial paper that came out a couple of years ago, what we did was basically impart a 5-part model about just recognizing ways that upstream factors shape downstream clinical implications, and then asking medical practitioners in the medical community to engage not just with treating health and illness in the clinical context, but really get out into the world and engage with treating structural factors, structural oppression. And in the initial paper, we laid that out. And then the paper that came out this morning, which I've just put in the links here, which I'm happy to talk about after, we then further that model by talking about what are the factors that are linked to the pandemic that can lead to doctors to become more structurally competent. And the answer we came up with is that the healthcare system needs to become structurally competent. And how is that done? We put out 4 different agenda items. The first one is that clinics themselves have to reimagine themselves. And they have to do that by imagining that they're not just treating health and illness, but they also become community hubs for fixing structural inequities, partnering with other businesses and other partners to address everything from internet connectivity to food distribution to legal issues for immigrant communities, people like that. And so in a way, we really have to reimagine what a clinic does in the context of a community. Another, of course, is a truth and reconciliation about just what has happened in this pandemic and what is highlighted. A third is to democratize information. In other words, communities and medical systems need to work together to, in effect, come up with community-based messages about public health and also about ways to fix structural inequities. And I think, kind of going down the line, the last part is to reframe the ways that we teach medical students, pre-health students, and all kinds of clinicians so that they can not feel at unease with these issues, but actually engage with them. And ultimately, I think what we're learning is that it certainly is the case that we feel like health and illness are these neutral terms, but what we're seeing in the pandemic is that it turns out health and illness are incredibly political, and it's time for medicine to recognize that and engage with the politics of illness and health. Thank you.
Thank you, Jonathan. And I'm looking forward to reading your JAMA viewpoint. I saw that just before we started the panel. So thanks for sharing more about that. And I'm sorry, I was so excited that Medicine, Health, and Society is now a department. So sorry I called it a center earlier.
It happens next week. So we're still a center.
Oh, we're transitioning. All right, great. Next, we're going to hear from Christy Sinkville. And Christy is the Director of Strategy and Innovation at VUMC. And, really, that's just one of her many titles. And I deeply appreciate that when I asked her, for a bio that she started with things that connect her to people. So she wanted to make sure that I acknowledged that she's a co-leader of our African American Employee Research Resource Group, which is newer and really serving an important role for our staff at VUMC. She's also, of course, a spiritual director, a sister, a mother, wife, grandmother, and a minister in the community. So, Christy, thank you so much for bringing your voice to the panel today.
Well, thank you, Consuelo, for this opportunity to participate in this very important discussion, and I'm grateful to share the platform with my colleagues. Today, my opening statements are coming from a place of a personal position that resonates with many people I encounter as the co-leader of the VUMC African American Employee Resource Group, as Consuelo mentioned. And I want to shout out to those of you who were able to join the call. I know we reached our maximum, so hello, my co-laborers with the AAERG. As Consuelo mentioned, I am the Director of Strategy Development for VUMC, and we do many things to help move forward the long-term strategies of the medical center. But I'm also a spiritual director, just as Consuelo said. I'm a mother, I'm a grandmother, I'm a sister, I'm an auntie, I'm a wife, and a minister in the community. And I want to start my statement by first sharing a quote from Father Greg Boyle. He's the founder of Homeboy Industries in Los Angeles, California. And this is what he says: "It would seem that quite possibly the ultimate measure of health in any community might well reside in our ability to stand in awe at what folks have to carry, rather than in judgment at how they carry it. Every Black person has a personal and communal story of injustice and unfairness in our lives. Every single one. From our communal experience of the murder of George Floyd, which we all witnessed on national television, to Breonna Taylor, a Black woman who on March 13th was shot dead by police who stormed her home as she slept while searching for a suspect who was already in custody. To Ahmaud Arbery, a 25-year-old Black man gunned down by a father and son as he jogged in rural Georgia. To personal experiences where I have been mistreated, received hate mail for taking a stand against racism, and have been concerned and afraid for my own children and my grandchildren. I'm saddened to say that it's good that our pain is on public display. Maybe now you will know it's not because we're inciting a riot, high on drugs, or just being shiftless and lazy. These are present day acts of violence against a people because we are Black. And these acts of violence have been our story for over 400 years. Conversations with family have always included the police talk. And these days it's not just reserved for our boys and our men. Black women suffer violence by the hands of the police. All you gotta do is Google Black women killed by police, and you will see this frightening reality. The fight for freedom and justice takes a toll on our minds and our bodies. The clinical experts here can speak to disease and the maladies associated with prolonged violence and trauma. I can speak to what it does to our souls. We get tired. We cannot seem to relax. The headaches increase, the depression and incessant crying. We carry the burden of racism in our bodies, and the burden is heavy. But there is good news. I know I'm a little sober, but I am hopeful. As a people, we must remind ourselves of our inherent dignity and our worth simply because we were born. Ella Baker, a human rights activist and movement organizer in the 70s, said, "Brothers and sisters in the struggle for human dignity and freedom, each of us must take on the struggle for human dignity and freedom every day." If she were here with us today, she would say, you know, this is a nice gathering, but it's not enough. It takes organization, dedication, and the willingness to stand and do what has to be done when it has to be done. We have to go back and reach out to our neighbors, the neighbors who don't like to speak to us, and our friends who think that our actions don't matter. How will we use this moment? Watershed moments cannot be predicted, but maybe this is one. humanize the pain. I'm going to use bad English. Black people is me. Is every Black person you are acquainted with, you see out and about, you see in the plaza at Medical Center North, or walking the halls of 100 Oaks, or in the clinics and the hospital rooms. What we do in this time to change the face of unjust world, what will we do? Audre Lorde, another civil rights activist, said, each one of us must find our work and do it. What action can we take? Listen to Ella, talk to your neighbors, walk together, even if 6 feet apart, wear your mask, and decide how you can change mindsets that allows you and others to see us, to see me as less than. When you're in the room and you don't see one of us there, do a D&I pause. What is that? A diversity and inclusion pause, and ask yourselves, can we make this decision or that change without the people at the table whom the decisions and actions impact? Find local organizations like Equity Alliance, a Nashville-based 501c3 nonpartisan nonprofit organization that seeks to equip citizens with tools and strategies to engage in the civic process and empower them to take action on issues affecting their daily lives. Partner with local organizations like NOAA, Nashville Organized for Action and Hope, a faith-led coalition that is multiracial and interdenominational, comprised of congregations, community organizations, and labor unions that work to give voice to traditionally marginalized people. And I'll close with this quote from James Baldwin. He says, you ask what the Negro wants. We want exactly what you want, to be left alone, to be able to raise our children in peace and arrive at our own maturity in our own way in peace. We want to live, and we want to be treated fairly. We want to be valued as a human being, and we want it now. Hashtag enough is enough. Thank you.
Wow, Christy, that's so powerful and really resonated so much with me. Hopefully there are virtual hand clapping happening now. I think the what some people call weathering, the constant stress and pain from experiencing discrimination and the socioeconomic disadvantage that obviously has an impact on our biology, on our health, our mental health, our physical health. Thank you for describing that. It's sort of sharing from my point of view, the time being at home during this pandemic, where my 14-year-old son is going through a growth spurt and is now about the same height as me, and sort of imagining a world now for him, and even amplifying all of those concerns and the stress of being a mother of a young Black man. So thank you for sharing that. We're going to move on to Will. Will Furuyama is a rising fourth-year medical student at Vanderbilt. And I've gotten to know Will over the last year or so as he's been co-leading the Social Mission Committee, which is a group of engaged medical students at Vanderbilt who is really an impressive group of people, students who are dedicated to bringing social justice and health equity into the curriculum and into their actions, and really just thankful for the students who don't accept what's already here for them and are really pushing us to do better with our work and meeting their needs for education in this space. So Will, thank you for joining us today.
Thanks, Dean Wilkins. I want to first thank the organizers for inviting me to be a student voice on this panel with such accomplished speakers. It's really an honor and a privilege to have a platform when so many people are struggling to be heard right now. It's certainly a strange time to be a medical student, to be undergoing challenging personal and professional growth when racial violence is hyper-visible and true change feels eons away. The effects of this violence are not isolated to the sphere of criminal justice. Civil rights attorney Brian Stevenson succinctly frames the issue in an interview with The New Yorker. He talks about how America has fundamentally not reckoned with its violent history of 2.5 centuries of enslavement. He states the great evil of American slavery wasn't the involuntary servitude. It was the fiction that Black people aren't as good as white people and aren't the equals of white people and are less evolved, less human, less capable, less worthy, and less deserving than white people. This belief and its afterlives reverberate through medicine and medical education. In medicine as a whole, it is most clear in race-based medicine that Dean Wilkins spoke about, where health disparities are blamed on intrinsic physical differences in Black bodies. While countless studies have disproven this claim, we still come across calculations for African-American kidney function and lung function, and the idea that Black bodies can tolerate more pain than white ones. These specific claims are rooted in the logic that justified slavery, the idea that Black bodies were built for physical labor. The continuation of this logic to explain racial health disparities detracts from efforts to tackle the root cause of said disparities, namely the human structures that prevent Black achievement, health, and safety. These beliefs and structures are present in the everyday lives of Black medical students. In an immediate and commonplace way, Black medical students must navigate the demanding expectations of being a medical student while avoiding or respectfully dealing with a minefield of opinions and microaggressions from attendings, residents, clinical staff, and sometimes even the patients they care for. They must regulate themselves to appear thoughtful and moderate in response to racist beliefs and violence that are thoughtless and extreme. On a systemic level, Black students often do this in a setting bereft of mentors and advocates, the result of decades of exclusionary policies, and now the product of inertia and an unwillingness to acknowledge the immense value that Black students bring institutions. Without exception, every Black student that I've interacted with has taken tangible steps to improve the pipeline to medical school, to partner with communities, and address barriers to diversity in healthcare. I want to close with an acknowledgement of the ongoing work that students have done to address these barriers. I want to start with Vanderbilt's Student National Medical Association chapter, or SNMA. They sustain ongoing mentorship programs for minority students, formal educational events about police brutality and structural racism, and actively recruit underrepresented students to the School of Medicine. They do this work often without fanfare and sometimes to the detriment of their CVs, as other students work on research projects that are prized markers of a productive medical student when applying to residency, the next step in their careers. Other students at Vanderbilt have independently begun creating protest safety kits, organizing forums, and advocating for a more comprehensive curriculum about social determinants of health, the myth of biological race, and the true cause of racial health disparities, namely racism. While many feel weary from the notable resistance to a simple refrain, Black Lives Matter, I remain in awe of my peers who have committed their talents to solving the racist beliefs and violence that we have inherited. It is indeed a strange time to be a medical student, and I thank you for your time.
Thank you, Will. We appreciate your remarks. And I'm going to start with a round of rapid questions. I'm going to ask everybody one quick question, and then I'm going to get to some questions in the chat box. Derek, I'll start with you. Black Lives Matter. What do you think we should be saying or considering around that phrase, Black Lives Matter? What should we be communicating to healthcare professionals? What should we be discussing around the table or the virtual lunchroom table right now within the medical center around Black Lives Matter?
Well, thanks for the question. I think the most basic thing that I've tried to do in my work around racism, institutional racism, is to bring it back to, not getting too distracted with all the other things that are going on outside in the world. So, if your job is as a physician, your job is as a nurse, your job is as a practitioner, the question you need to ask is, what do you need to do differently in your particular role to best serve your patient or your person that you're serving? So if you know that person is probably experiencing a lot of stress based on all the various things that are going on, if they're, unnecessarily at risk for certain things based on the kinds of things that are going on, likely experience a lot of trauma, that you ask about those and you engage those kinds of things and you at least explore what can be done within the confines of your specific role to support that person, to help that person, and make sure that they get access to the services that are within the confines of your particular job. Yes, you can do a lot of things outside of that. You can engage with these other conversations and so forth, but I don't want people to miss and get distracted with these larger opportunities that are things that they should do in addition to doing your best job with your patients. So I'm not saying don't do those kinds of things. What I'm saying is your primary role has to be fitting within your particular job. Yes, I need you to advocate, stand with me, and do other kinds of things outside of your job. But it, to me, is most important to figure out what you can do best and deal with the stress, the trauma, the experience, the physiological wear and tear on the body that your patients, the people you're seeing, are dealing with. And how do you make sure that you provide the best quality care to them?
Thank you, Derek. Jonathan, this question is for you. Why do you think it's so hard for some people to say the word racism? And not to be not to say that it's only white people that have a challenge saying the word racism, but perhaps, at least in my experience, it seems that it's more challenging for people who are not of color.
Oh, how much time do we have here? You know, I've been thinking about this a lot because it just comes up, and I think it's safe to say that we are largely talking about white people with that kind of defensiveness, and I think there are hints in a bit about what Christy so powerfully talked about, which is people are afraid of being part of a system, right? It's a hard conversation to have, a much harder conversation to have. And when you talk about race, that's something external, but when you talk about racism, that implicates me, you know, that implicates us. And so in a particular way, the recognition now, and it's funny because I have a book called Dying of Whiteness that's out, I've been getting asked this question a lot, like, what can I do? What can I say to my colleagues of color, you know, as if I would know that really the answer is, number one is to listen, right? Number one, I think it's the responsibility, if you want to have a conversation about racism, to listen, right? And in other words, a lot of the things that Christy and Will and Derek and we're talking about are things that is an everyday experience of pain, things that it's crazy to think about, like Du Bois and Fanon and Baldwin writing about these things, and now we're 56 years later, and the experience is the same in a way. And so part of it is to recognize that you're part of a system that benefits you in a hierarchy in a particular way. And I think that people get defensive, because then it means, how am I complicit? What do I need to give up? And ultimately, I think that those are the kind of hard, powerful conversations that we need to be having. But it's not a feel-good conversation, right? Because it's not just about individual interactions, like, oh, I'm not racist. It's about how there's a system, a hierarchy set up. And then another part is that there are moments where these conversations are particularly important. And for me, that moment was the beginning of the pandemic, right? Where all of a sudden the pandemic hits, and it became pretty clear pretty quickly that the people who were the most at risk were people, minoritized populations, black and brown people. And at that moment, we had a decision to make as a society, which is, were American lives dying, or were their lives dying? And I think that from the politics of the United States, it was basically like, this isn't happening to me, this is happening to them. And for me, on one hand, it was just another example of the ways in which this kind of racialized discourse of, well, why should I care because it's happening to them? And think about, for example, gun violence. Oh, well, why should I care because that's happening in an urban area? It must be a gang shooting or something like that. On down to health disparities and factors like that. The system itself is the problem, right? And so in a way, when we didn't say Americans are dying, when we said they are dying in the beginning of the pandemic, it just reified all of these truly racist, inbred structural tensions that are baked into the United States, right? This idea that basically, why should I care because it's happening happening to them. And to me, that was the precursor to what we're seeing now, right? Because it said that all lives don't matter the same. And it was a lost opportunity. And so part of the issue about talking about racism is to recognize those moments, because I think that there is a moment there where we are all connected in this particular system, and this system oppresses certain people more than others. But I think we can't let moments like that go by again, because it just reinforces what I think people so profoundly feel is kind of linked to what Derek was talking about, which is we see these moments as the tip of a very, very, very large iceberg, which is something people feel really deeply. And I think it's important for white Americans to be asking and listening and then talking out.
Thank you. Christy, as given that you have, you get to hear from so many of our employees here, is there something that you'd want to make sure we all hear from the group? Things that I'm sure as you and Mamie and others and Claudia are hearing from employees. Is there something that you'd want us to know?
Yes, thank you for the question. That's a great question. What we are finding, we started the African American Employee Resource Group in October 2019. And it has been a great networking, a great opportunity for many of us to get to know each other that we would never have known each other. But what has been very interesting as a result of the start of this group is how many emails Mamie and I get from our fellow employees who are saying, what do I do about this manager when I feel like I'm being unfairly treated? How do I fight the battle when I've tried to prove myself? I work hard, I do the right thing, and I don't get the promotion. What I'd like to share is that if you could just for a moment put yourselves in our shoes. We've been told no for so long. We have not been given the opportunities for far too long. So co-workers, managers, directors, leaders, would you take just a moment and understand how our sensitivities are probably heightened? And if there's a reason why we're not promoted or given another opportunity, make sure that it is very clear and it's based on fact and measurables, things that are not, subjective, because it doesn't feel fair. We're hearing more and more of this. I wish I could solve the problems that so many come to me about because I'm a problem solver. But what I would encourage each of us to do is to pause. I think Andre Churchill, somebody came up with a D&I pause. Pause before you say that thing you're getting ready to say, before you make that decision that you're about to make. Consider what you're doing and the impact of what you're doing. And do something different. It starts with each individual choosing to do something different. Thank you.
Thank you, Christy. I think you're answering some of the questions. I think there are at least a couple of questions related to that in the chat box. You know, what do people do when they're not being heard? Maybe I would add to that, you know, the measurable outcomes. But also, are we looking at the right measures? Because sometimes we're not really considering those things that Will brought up about, you know, all the contributions that, you know, students of color are making to the environment and the culture, but those aren't actually valued in promotions, decision making, and that certainly happens to faculty as well. Will, I'll ask you quickly if there's anything that you'd like to share about something you wish would change in the curriculum or in your education and training so far that you've seen.
Yeah, I mean, I think a lot of different medical schools are working on like trying to implement structural competency in a way that's engaging for all medical students, in a way that addresses like race-based medicine. And I'd really like to sort of see that implemented at the medical school at Vanderbilt in a more concrete way. I know that's something that we are working on, and there's a lot of interest from deans and faculty, but I think like because of all the attention on this issue right now, now's a really good time to push forward with sort of a really comprehensive and coherent thread around addressing racism.
Thank you. And we have lots of questions. We won't get to all of them, so I'm going to try and ask a few, and then we'll do our best to actually answer the others and put them on our Office of Health Equity website. Let's see, if you're currently in your training, how do you address racism or exclusion while minimizing consequences there? So certainly that's a power imbalance there. How do you bring up these issues? I'm sure for not just for yourself, but also for patients if you're seeing them. Does anybody want to take that one?
I guess because I'm still in training, I can talk to this a little bit.
Yeah.
And I think I can speak, I think a lot of times it's a really challenging line to walk, right? So if someone is in a position of power, they will select you for residency and they say something that's off color or even make a remark about like the acceptability of protests or about Black Lives Matter. Like it's really hard, I think, for a lot of students to navigate that. I think there are some really wonderful resources at Vanderbilt for students to go to, like Dean Vincent and Dean Churchwell. There's really wonderful faculty and staff, but I think also it's a really hard line to walk. And I think the thing that I've seen most effectively is for a top-down approach. So like when departmental leadership says like these kind of behaviors are not tolerated, or when chairs of departments make statements about issues of racial injustice, I think like that is when change starts to happen for folks.
Yeah, that's important. So, but a dual message there. You know, the leaders need to speak out, but also people need a place to share their concerns, perhaps confidentially or anonymously. Jonathan, were you going to add something there?
Well, just that I want to agree with Will that on one hand, you know, residents and medical students are the voices of change right now. We're seeing this in so many phenomenal responses. It's not just now. We had white coats for Black Lives way back when and on down. So medical students have been the drivers of change. And part of what the issue has been, I think, is that it's not been top down enough, right? And so part of the issue is that when medical students go on in their training or you know, it's not like the system is not set up for that kind of social justice work. And so part of what we wrote in the JAMA piece was that we actually need to make social justice and health equity a component of training for a clinician. We argued that we need a new Hippocratic oath, a new medical board, a new set of this needs to be central to what it means to be a doctor, is to understand this relationship between the clinic and society, and also recognize that addressing these issues are better for everyone. We're not just talking about particular treatments of particular groups of people, but if we had a system that's more horizontal, you know, it's actually a system that would make being a doctor a lot better because people would actually be healthier out in the community. But I definitely agree that on one hand, bottom up is driving the change here, but this also, if people don't get that, they shouldn't be a doctor, honestly. And I think this needs to be as central to medical training as many other aspects are.
Thank you. We're down to our last minute, and boy, this hour went really fast. Lots of great questions in the chat box. And I'm sorry we won't be able to get to all of them. Special thanks to Derek for answering some and putting all the resources there. We will have more of these, so stay tuned. We'll try to make others more specific to questions, and if you have suggestions, please let us know about those. We will also be posting links, if it's already there, links to resources, anti-racism resources, which are being housed on our website. And again, really thank you to everybody who joined today, but also especially to our panelists who have done, you know, brilliantly and in such a short, you know, period of time. I'll give you all a last 10 seconds if there's anything else you feel like you wanted to say before we close here. And I'll go in reverse order this time. So Will, anything else you want to add before we go?
I don't think so. Thank you for listening, everyone. And I appreciate all the people who have taught me all of these things in the past.
Thank you. Christy?
I echo Will's sentiments. Thank you for listening. Thank you for being here and for the chance to just share.
Okay. Jonathan?
Thank you so much. It's remarkable to have this conversation at Vanderbilt. please, please let me know how I can help.
Thank you. Derek?
Last thing I'll just quickly say is I think it's important to do these things together and to not try to do these things alone. It's going to be important so that you protect yourself in these moments and in these efforts, that you work with others and organize others to get those kind of things addressed. You can't do this by yourself. That will put you at further peril. So work with others and do this work.
Great. Thank you all again, and thanks to my amazing team in the Office of Health Equity here at Vanderbilt, and for everybody who supported us. Have a great day, everyone.
Thank you. Bye, everybody.